Good evening, everyone present here. I am Faraz from IJCP. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, Professor Dr. Madhulata Alexander ma'am. And now let me share some of the achievement of ma'am. Ma'am has done MBBS, MD in OBGY, and professor at Osmania Medical College, Hyderabad. And today she is going to speak on a very important topic, that is updates on the safety and efficacy of HRT. So, to more about this topic, I would like to invite ma'am and hand over this session to ma'am. Ma'am, over to you, ma'am. The stage is yours. You can proceed from here.
Yeah, yeah. Thank you for us. I think this is a very important and relevant topic from our point of view because of the number of people in this older age group is steadily increasing. Uh, Actually, if you see the first picture, the topic is a young woman. The young woman on the left side is a part of beauty, but an older woman is a work of art. You'll see what I'm talking about in the next few slides. What is menopause? Menopause is not a pause, it's the beginning of a new life. It's a transition from the reproductive to non reproductive part of a woman's life. And how do we diagnose menopause? By 12 months of amenorrhea. When the woman has 12 months of amenorrhea, we say that she's undergone menopause. So, therefore, it's a retrospective diagnosis. If you look at a woman, there's no independent biological marker because what is happening now is more and more people are wanting to have kids later on in life. So when their periods become irregular or they feel they're going through menopause, having menopausal symptoms, they come and tell us, Madam, please give us some tests. We get tested out. Are we undergoing menopause? And of course, our Google doctor will come readily into reckoning, and he will give us some vague kind of advice, but we know that's not correct. Now, what are the basic tests? People, we also have to be objective. If the serum FSH is about 40 milli per ml, maybe it's undergoing menopause. Estradiol, the female hormone, less than 20 picograms. Inhibin B is low, and the ultrasound of the ovary is showing less antral follicular count. Now, do we really need HRT? Why are we talking so much about it? What is the mean age of menopause? In India, it's about 46 years. Worldwide, it's about 50 or 51 years. Now, in India, the life expectancy in female is about 70.3 years in the WHO. In women, is in India slightly less. But the main thing is in the India, the female menopausal population, the population beyond 50 years, has doubled since 1991 to 2016. So more and more people are living in this age group, and the quality of life, people are demanding a good quality of life also in this age group. So what can we as doctors advise them? What are the various updates in the menopausal hormone therapy? 10% of India's population aged over 50 years, that's quite a lot. That's about 100 million. And in this older age group, there is something called NCD. The non-communicable diseases are steadily increasing and leading to about 60% of deaths. So our focus should be on other things. What is premenopause? It is the reproductive period prior to menopause. So probably all of us, all the younger people who are having regular cycles, who are able to have children, is undergoing premenopause. Perimenopause is about 3 to 5 years before and 1 year after menopause. So it's a sort of a retrospective diagnosis. Because as you know, tuck at one, you cannot just say, okay, today I've undergone menopause. No. It takes some time, and also you do it as a retrospective diagnosis. Menopause transition is when the problems start. When you start thinking you're going to undergo menopause, there'll be a disturbed menstrual cycle and with various endocrine changes. Premature menopause is when you attain menopause less than 40 years or less than 2 standard mean menopause for that population. So in India, it's about less than 40 years. When you attain menopause less than that, it's called premature menopause. Now, what are the various symptoms in the transition period of menopause and beyond? From about 40 years, probably the earliest symptoms and or what the symptoms the patient will come to the doctor will be vasomotor symptoms. The patient will feel hot, she'll have hot flushes, sleep disorders, and mood changes. But I find nowadays even young people are having mood changes, which they attribute to their menstrual hormones. Now, around 46 to 60, when we attain menopause, the other changes that occur are the urogenital atrophy and the dyspareunia because of the dryness of the vaginal mucosa. Menstrual diseases probably is the hallmark of menstrual disorders, probably the hallmark of menopause. The later problems that occur are osteoporosis, atherosclerosis, coronary artery disease, CAD, and cerebrovascular disease, CVD. Now, what are the changes in the menopause hormone therapy? Generalization. You don't put all of them in one group and start treating them. No, you don't generalize the population. You individualize the treatment. You treat each patient singly and you treat each patient according to what they need. Before, we used to give hormonal therapy for all the postmenopausal women, but now we don't. We only use it for within 10 years of menopause and only for symptom relief. If the patient is not having any symptoms, generally we do not advise hormone therapy. Before they used to do long-term use of it. Okay, they used to use it for long term. Nowadays, no, it's used only for short term. And hormone therapy offers protection, CVD protection, cerebrovascular protection at all ages. They used to, but no, nowadays it's not used for primary or secondary prevention of CVD. Before they used to give a standard combination fixed dose, continuous combined regimes was used, but nowadays we are using better drugs. We are using natural estrogen, progesterone, low dose, using low dose progesterone, and only the therapy that is minimally effective. Before they only used to use the oral route, now they use oral and German route. What are the benefits and risks for women who initiate MHT, menopausal hormone treatment? What are the things? There's something called a window of opportunity. That is, when we start MHT or menopause hormonal therapy, we start it usually around menopause. We do not start it beyond 10 years after menopause or beyond 6 years. And it is more favorable, the effects are more favorable if the patient is less than 60 years old or within 10 years of menopausal onset. But it is less favorable when it is more than equal to 60 years, 10 years from the menopausal onset, and the patient is having more risk. It is an absolute candidate for coronary artery disease, stroke, thromboembolism, and dementia. Now, when the person comes to the clinic, this is an easy, quick 6 questionnaire what we are following in our hospital. We look at 6 questions. Any change in your periods? Are you having any hot flashes? Any vaginal dryness? Any bladder issues? First 4. If the patient answers yes to any of them, yes, the patient should be evaluated further. And the last 2 is how is your sleep? How is your mood? This the menopause International Menopause Society guidelines say ask all 6 questions to your patient for you to have a better picking up of patients who really need the menopause treatment. What are the latest advice in when to prescribe them MHT? When to start? What therapy? Which route? Which regimen? Tracking the side effects? How long to give and when stop? What I'd like to say is, if a patient has come to you for menopause treatment, menopause, and you're thinking of hormones, there's no need of doing some tests, sending her back, asking her to come back. As of now, the current recommendation says there's no indication for a pre-treatment mammogram, although we know we are using hormones that may cause breast cancer. We do not need to do a mammogram or a breast examination. We need not do a pelvic examination or a cervical smear, endometrial thickness, or a transvaginal scan. Unless there are other indications for doing these tests, there is no need to do these tests before starting treatment. Always must remember that these comorbidities, that is the metabolic syndrome, dyslipidemias, uncontrolled sugars, history of blood clots, heart disease, breast cancer, thromboembolic disposition, and obesity. If any of these are there, please be careful. Be aware. There are hormones. You have alternative to give the hormones. There are various routes of giving the hormones that may decrease these comobs. So when a patient comes to you, what do? You classify them into four: healthy with no risk factors, healthy patient with risk factors, healthy with latent disease, or with overt disease like diabetes, hypertension, etc. What are the indications? The vasomotor symptoms, the patient is feeling hot and cold. Probably this is the most common reason why the patient will seek treatment. Genital urinary syndrome, yes, it's also important because the patient has a dry feeling in the vagina. She has urinary symptoms. These all may contribute to the reason why she has come to visit you. Bone loss is a very important part, but patient will not know it. Osteoporosis and all are silent diseases. Patient will not know it. And but if a patient has undergone premature ovarian insufficiency or castration, or we remove the ovaries, these patients also need hormonal replacement till about 50 years till they attain natural menopause. What are the contraindications? Patient are there some indications you do not give MHT. That is, if there's any hormone dependent cancers like what? Like any endometrial cancer, ovarian cancer, all these cancers we do not give. Any active breast cancer or that somebody has got estrogen progesterone receptor positive cancers, then we should not be giving MHT. If a patient is suspected to be pregnant, if she has any undiagnosed abnormal vaginal bleeding or severe active liver disease, gallbladder disease with impaired liver function tests, family history of VTE, venous thromboembolism, SLE, these patients we do not consider giving MHT. What are the various estrogens? We use this oral estrogen, 17 beta estradiol, estradiol, valerate, or conjugated equine estrogen, that is 0.625. It's derived from urine of pregnant horses. It's called CEE. These are very mild compared to the potent estrogens we use in the contraceptives, that is the E2. Okay, these all we do not use in MHT. What are the various routes? Oral routes before we give it. Now we are giving transdermal patches. Vaginal creams also are being given, especially for dryness of the vagina. Why are we giving lower doses? Because you remember, one type of hormone cannot fit all populations. It's not like one drug for all, as I told you. And we are getting the benefits with lower doses. Okay. So therefore, we are minimizing the risks and possibly side effects. And patients are also, any patient, they come to us in the OP, they tell us, Madam, I don't want drugs, I don't want high dose. So if a patient knows that she's going to take a good drug at low dose, probably she may be more enthusiastic and more compliant to take the drug. Efficacy in prevention of osteoporosis. Be careful, as I told you, osteoporosis is a silent killer. Role of progesterone. When do we give progesterone? We give it when the uterus is intact, because estrogen, what is the hormone that is missing in menopause, for that it stimulates the endometrial lining. So therefore, progesterone adding after PEPI trial, it showed that adding progesterone prevents endometrial hyperplasia. And progesterones, before, if the patient is hysterectomized, there is no uterus, there is no need of giving progesterones. What are the various types of progesterones being used? Methyl progesterone, norethistosтерone, micronized progesterone, and dydrogesterone are giving very good results. Okay, they do not have the side effects. They do not have the cancer-causing effects. The WHI, all these studies are a big part and parcel of how the menopause treatment has evolved today. The WHI, or the Women's Health Initiative, they said that progesterone is the component that causes breast cancer risk. So therefore, minimize progesterone, decrease the dose, and replace progesterone by the SERMs, selective estrogen receptor modulators. These do not adversely affect the breast, and they also inhibit endometrial proliferation. I told you the most common causes why we take the MHT is the vasomotor symptoms, occur as high as 75%, and it lasts for about 6 months to 2 years usually. Sometimes patient goes on with these symptoms, which is very bothersome. Then we go on to other treatments. What we do is we give estrogen, oral or transdermal, and also add progesterone if the uterus is intact. Micronized progesterone, I told you, is having very good results. And of course, now the Marina or the LNG IUCD has also produced very good results. What are the various options? How the patient will ask you, madam, how should I take my MHT? Now, if the patient does not have the uterus, see here, if the patient does not have the uterus, give continuous estrogen with no tablet break. Continuously give it. It's very easy to follow. But supposing the patient is having the uterus. Now, many patients think, which is very wrong, that having a period every month, okay, is very good. It's good for health. They're getting detoxified, but however much you tell a patient, they're not being convinced. So they prefer the cyclical HRT, that is, you give estrogen for 7 days, then from 7th, 14th, 7th day, you start giving progesterone for 14 days, and then you take a break when the patient has a period. Or you can give continuous sequel HRT, that is, first half you give estrogen, second half you give progesterone, the patient has a break. And the continuous combined HRT is very popular, where you give estrogen and progesterone without a break. So these patients will not have bleeding PV. This estrogen can be given oral or transdermal. The the genital urinary syndrome, patients usually present with dryness, pruritus, dyspareunia. This is a very important symptom or urinary urgency. First, what we do is before starting treatment, we try with vaginal lubricants or moisturizers. If it doesn't work, then we go ahead with estrogen therapy. Now, if the patient needs estrogen, this estradiol, that is this Evolon cream or the estradiol vaginal cream, the best part is they do not need follow up. Anytime we give estrogen, we avoid is the endometrium getting thickened? Is it getting hyperplastic? But when we give this local preparation, there's no need of doing the endometrial thickness. You do not need to give progesterone support. Start a daily dose for 2 weeks and then you make it twice a week. If they have unscheduled bleeding, then you have to evaluate. What about coronary vascular disease? Estrogen alone. If you give estrogen alone, this may decrease the risk of MI in women. Okay, this has been found, but when you add progesterone, the data has been less evident, okay, or inconsistent. Now, when they started giving estrogen alone, in especially women who were younger, they have found that these patients had a lower chance of myocardial infarction. Transdermal, when do you give transdermal estrogen? When there is risk of thromboembolism, hypertriglyceridemia, the patient is having hypertriglyceridemia, obesity, smokers, or glucose intolerance. Breast cancer, we should not give patients, however small the risk is, if the patient has the risk, we should not be given. But remember, it does not worsen the benign breast disease. And the breast cancer survivors, you can give non-hormonal. Even vaginal applications may be of concern. What are the benefits or risk profile of MHT? If you consider breast cancer, estrogen alone with hysterectomy, it decreases the risk. But without hysterectomy, some patients have the uteruses. When you combine the estrogen with progesterone, probably it's associated with cancer is less, probably related to duration of use. But emerging data is showing that if you use progesterone, which I told you is the contributor of the breast cancer, or dydrogesterone, the fourth generation progesterone, with estrogen, there is no increase of breast cancer if used for less than 5 years. And this benefit will go on for the next 2 years also. If the patient is obese with insulin resistance, use micronized progesterone or dydrogesterone. The last part I'm going to talk about is osteoporosis, which is the most serious long-term consequence of the estrogen depression in the menopausal period. On the left is a healthy bone, on the right is the osteoporotic bone. Now, if a patient is having osteoporosis, anybody who we are suspecting, the first line of therapy is the bisphosphonates. Okay, the bisphosphonates is the most important, the first term of the one that is causing give. But if a patient is a young patient who has had castration of the ovaries, removed ovaries for whatever reason, we do not give bisphosphonates at the first line. We straight away start on hormone replacement therapy. It may be used, estrogen progesterone therapy or estrogen may be used for prevention and treatment in early menopause in symptomatic women unless there's a contraindication. What we are commonly using is the SERMs, tibolone, raloxifene, bazidoxifene, and more commonly now is the teriparatide, which is which is come later and it's little expensive, but it's being replaced. Tibolone is another synthetic steroid with estrogen, progesterone, and testosterone. Especially the woman has low libido and just come to you thinking it's a complaint by her or her partner. It's a better deal to give Tibolone because it's good for vasomotors, genitourinary symptoms, osteopenia. We can safely give it 1 year after menopause. What is the benefit or risk profile of MHT with osteoporosis? It significantly lowers the risk of vertical and other factors. You should start it before 50, 60 years or within 10 years. Sometimes they start after 60 years, but you can start it. We have seen people starting, but this should not be first line. It should be second line. And when starting it, the lowest effect should be used. Strontium. This is another drug which significantly reduces the risk of vertical and non-vertical fractures in osteoporotic and osteopenic patients. The mechanism is bone formation and inhibition of resorption. It started with a lot of fanfare, but somehow it did not pick up, and now I think very few people are using it. Nilosobam is another drug which is being very popular, being pushed by the drug companies. You need long-term studies for us to recommend it. It's a monoclonal antibody. It's given a dose of 60 mg subcutaneously every 6 months. It reduces the risk of vertebral and non-vertebral fractures, but we have to see how it is. Ospemifene is another SERM that is becoming popular, and it's a once-in-a-day oral dose. Dyspareunia with intact uterus. The patient is having the uterus. She is having dyspareunia. This is approved by FDA. It is the only non-estrogen compound approved for dyspareunia, builds up the vaginal wall thickness. It doesn't seem to have any adverse effect. The side effects are hot flushes and vaginal discharge. What about dementia and cognitive changes? Initially, when MHT was being used, they thought it is also going to help in dementia and cognitive changes. But as of now, current studies do not seem to support this. What's the follow-up? As I told you, when starting MHT, you do not do any tests unless indicated, but follow-up. When the patient comes back to you, it is mandatory that you follow up. You have to counsel. You have to examine her. Efficacy, see the side effects and compliance. Check the weight, check the blood pressure, do a physical examination. Do go back into her medical and family history. Do relevant lab and imaging investigations. Discuss lifestyle and review. Are you going to continue? Many patients do not like to continue. As I told you, they all say, oh, I don't want to take medications. So you may convince the patient to continue it because some patients need it. Also be careful and rule out any pelvic pathology if persistent or unscheduled. Now, at the last slide of the mine will be bioidentical hormone therapy. What is this? Who is the beautiful woman on the right? That is Angelina. She swears by it. This is nothing but processed hormones from plants having estrogen, progesterone, and testosterone. It is nothing but mixed bioidentical hormones. It has not been tested, not approved by FDA, but claim is supposed to be very good alternative medicine. But however, these need to be supported. There are also other studies, that is black cohosh, all those things, soya, but more studies have to be there for us to recommend it in by the menopause societies. What's the take-home message? Choose women well. Start early. Individualize each patient. Plan the screening. Risk. Is it necessary at all? Is it necessary? Is the patient needing MHT? Choose the drug and the dose with low maintenance. And remember, there's no role of prevention. Lifestyle modification is absolutely necessary to address the comorbidities. Thank you.
Thank you so much, ma'am, for taking your precious time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants. So, with all,
I'm not able to hear you. Hello?
Can you hear me? Yes,
Yeah,
ma'am.
now I
Am
can
I
hear you.
audible?
Yes.
Just a second, ma'am. Can you hear me now?
Yes, I can hear you.
Hello.
Yeah, hello, I can
Yeah,
hear
ma'am.
you.
Thank you so much, ma'am, for yeah, ma'am. Thank you so much, ma'am, for sharing your important knowledge on this topic. I definitely think this session knowledge is going to help all the participants. I have received some question. With all your permission, shall we take these questions?
Yeah, go ahead.
Yeah, the first question is from Dr. Ayushi, and she's asking what are the genetic and metabolic factors that may influence a patient response to HRT?
See, I think there are no studies. All the studies I have got, there is no genetic response. There are no studies regarding genetic response. Okay, it may have to come. Maybe the doctor has to do it. Other question, Mr. Faraz. Genetic and
Ma'am, the question, let me
genetic.
repeat one the question. The
Uh,
question is what are
yeah,
the genetic and metabolic factors? Metabolic factors.
metabolic factors. See, I told you, no, all those things. That is, if you're obese, if you're having hypercholesterolemia, diabetes, all these things also, you can give MHT. So better to give them because the patient, I told you, each patient has to be individualized. So instead of giving oral drugs, you can give transdermal. This is a third indication of transdermal. And also, these patients may need a pre-treatment checkup and also more close. You have to follow them up. Okay, so you can try the transdermal route for these patients.
Thank you so much, ma'am, for sharing your knowledge on this question, ma'am. Like moving forward, I can see another question from Dr. Shivangi. She is asking what are the latest finding on the risk of breast cancer associated with long-term HRT use?
See, okay, this is very good question. As I told you, the progesterone, when we give MHD, if the uterus is there, we give estrogen and progesterone. It is the progesterone that contributes to the breast cancer. Okay. So what we can do is lower the dose of progesterone in a patient who's susceptible. Lower the dose or give alternate doses. That is, you have the SERMs, you have other drugs you can give. So be careful, follow the patient more closely, lower the dose, give alternate routes and alternate drugs like the SERMs, they also may help and they will not cause breast cancer. Okay. So you have to
Thank
tailor
you so
the
much.
dose and the drug. Okay.
Yes, ma'am. Thank you so much, ma'am, once again for sharing. I hope that Dr. Shivangi has received his answer. Moving forward, ma'am, one last question from Dr. Harshita, and she's asking how does HRT impact the risk of endometrial hyperplasia and cancer, and what are precautions should be taken?
See, endometrium hyperplasia, how does it come? Comes because of the estrogen component. Okay. So if the patient is in the uterus, if you are starting MHT, the therapy, you must give progesterone. Progesterone can be given in various ways. Nowadays, what we are doing is instead of giving the drug, we are putting the Bina, LNGIU. We are doing in our hospital. I work in the public sector. We have a lot of patients. They're getting good results. We put the Bina and forget about it. Okay. Apart from that, you can give lower progesterones. There are alternatives you can do, but these patients you must monitor the patients, monitor the endometrial thickness. Okay, periodically. Anytime any unexplained bleeding, stop, reevaluate, and only restart the drug once you're convinced there is no cancer. Sometimes we also have to do endometrial sampling to rule out malignancy.
Thank you so much, ma'am, for answering all the questions, ma'am. I hope, ma'am, you have done justice to this topic. As I can see, there is no more question from the participant. I hope that they are clear with this topic, ma'am. As there is no more question, with all your permission, shall we conclude this session for today?
Yeah, yeah. Thank you for
Yeah,
us.
ma'am. Yeah, thank you so
Okay.
much, ma'am, and we would like to see you in future also with different topic. Till then, take care of
Yeah,
yourself, ma'am. Thank you so much.
yeah. Thank you.